So thank you very much for this honorable invitation, Professor Constantine. It's my privilege to speak at the occasion of the National Day in Romania. And I would like to elaborate about the treatment possibilities of soft tissue defects at implants. And basically, we are going to discuss another topics like treatment goals, some etiological factors, some specific techniques on how we can improve the situation, and also looking at different biologic principles that are important. So what do we need when we talk about stability around the implant, soft tissue stability and hard tissue stability, aesthetic outcome? We need, of course, two components. We need the hard tissue, we need the soft tissue, because only if these two parts are matching with each other, we can ensure long-term function and also long-term aesthetic. So when we talk about hard, because it is mandatory when we talk about implants, we are never going to have a soft tissue stability without the stability of the hard tissue. So the first step is, of course, always the direct contact between the bone and between the implant surface and the so-called osseointegration. Without this, nothing will function. But this biologic principle is very well described in the literature, is very well known, and we have, in the last, would say, 2 decades, acquired more and more information about the so-called importance of the soft tissue seal, the so-called soft tissue integration, because in fact, when we are dealing with biologic complications, the biologic complications start always at the cervical part of the implant, namely in the area of the soft tissue. That's why we need a very stable soft tissue coil in order to prevent plaque accumulation and further infection in this area. When we discuss around teeth and around the implants, it is very important to look at the differences in terms of anatomy, because when we look at the tooth, and this is a very, very important difference between an implant and the tooth. When we discuss the tooth, we have the periodontal ligament. And the periodontal ligament is a unique tissue. And this tissue connects, in fact, the tooth with the so-called bundle bone. This tissue is responsible for periodontal is a very highly vascularized tissue and has a unique composition also in terms of blood vessels. When we discuss the healing of soft tissues at implants, we have to keep in mind that we are going to have a direct contact between the implant surface and the bone. We do not have a periodontal ligament. We have a kind of ankylotic structure with a limited number of blood vessels and a scar-like tissue. And this is very important to keep in mind, because this will influence our clinical treatment and also the potential outcomes. When we discuss about the mucosa seal around the implants, we have 2 components. We have the junction epithelium, and we have the so-called connective tissue. The junction epithelium is always located in the area of the sulcus, and here we have a connection between the surface of the titanium and the epithelial cells via hemidesmosomes. When we look into a more apical direction, we realize that we have the collagen fibers, and these collagen fibers are oriented parallel to the implant surface. And of course, they are directed towards the bone, but they do not insert, like, for example, sharp eye fibers into the surface of the implant. Now, when we have a certain bacterial accumulation on a tooth, as you can see it in this histologic image, we have the tooth, we have the sulcular area, and we have, in fact, so-called subepithelial inflammatory infiltrate. Now, when we have the same amount of bacterial biofilm on an implant surface, we have more extensive and larger inflammatory infiltrate characterized by the presence of plasma cells. This infiltrate is not very well integrated into the connective tissue, is not encapsulated. And now when we look at the high magnification at the inflammatory infiltrate around the tooth, we see that we have an infiltrate, but also a connective tissue encapsulation of this infiltrate. When we look at the high magnification at the inflammatory infiltrate located at the implant, it is obvious that this inflammatory infiltrate is wider, it is not very well encapsulated, and we have a very fast progression of the inflammation of the infection towards the bone. This is also one explanation why, for example, a peri-implant infection, namely a peri-implantitis, will progress faster towards the bone than periodontitis. So when we look now at the stability of the hard and the soft tissues around the implants, we need to monitor our patients. This is very important. And when do we start the monitoring process? We start monitoring the patients always after the remodeling process of the bone. This is very important because then is the moment where we have the crown, we have the reference point, and we should not mix up the remodeling of the bone basically with peri-implant infection. So that's our baseline. We always take an X-ray, we always take a clinical photograph from the same angle. Then we monitor the case. We like to look at the cases always from the same angulation with the photographs, with the X-ray over the years. And in this way, we can ensure stability of the surrounding tissues. When we are talking about aesthetic parameters at implants, we have two components. One component is a so-called white aesthetic. The second one is the pink aesthetic. And for both, we have very well designed parameters that have white aesthetic score, Belzer index, and for the pink aesthetic score, we have the Furhauser index. And of course, both of them have to match, because if we have, for example, a wonderful crown, but we have a lack of soft tissue, the aesthetic outcome is not going to be perfect, and vice versa. So in fact, we have to have both components. Now we have to ask ourselves whether there are biologic differences between the soft tissue healing around teeth and around implants. I try to elaborate already a little bit at this aspect on the anatomical discrepancies. And now we did two studies, and both of them are published, and they are available online, open access. They were published this year. And in the first study, we asked a very simple question. The question was whether the soft tissues may regenerate in the same way around an implant and the tooth. So what we did is to insert implants at one part of the jaw in the animals, and the other side was the control, namely the teeth. the entire keratinized tissue was removed at both sides. Roughly 3 months is the formation of a new gingiva around the tooth. That means a new keratinized tissue. However, around the implant, keratinized tissue only formed at those implants that were located in the vicinity of the teeth. When the implant was accommodated alone, it was no keratinized tissue around it. So in other words, the keratinized tissue didn't regenerate around the implant, but regenerated around the tooth. And this is a very important information for us, because we know that if we lose the keratinized tissue around an implant, basically this tissue will not come back by itself. And of course, the keratinization can be more clearly evidenced by some specific stainings. Look at this reddish color. That's the keratin layer at the tooth, and we have no keratin layer at the implant. So in fact, we had some important conclusion, namely that we lose the tissue around an implant, but this tissue doesn't come back by itself. So what happens? To change the position of the keratinized tissue with the non-keratinized tissue at implants and at teeth. So this was the second experiment that was performed. And in fact, in this experiment, again, implants were accommodated, and then the keratinized tissue around teeth and implants was prepared as a split thickness flap and full thickness flap. And in fact, the non-keratinized mucosa was switched coronally, and the keratinized mucosa was sutured apically. And we wanted to see what is going to happen when we evaluate the healing both clinically and histologically. What you can observe is that at the tooth, we have a new keratinized tissue that we formed at the cervical part of the tooth. Then we have a non-keratinized epithelium, and then we have, again, a keratinized tissue. When we look at the implants, then it is obvious that the tissue didn't keratinize. However, apically, the keratinized epithelium remained keratinized. And this was very clearly distinguishable in these histologic sections. So what we concluded now, based on these experiments, was that the keratinized tissue that is transpositioned apically remains keratinized. However, the non-keratinized epithelium doesn't keratinize around the implants, but it keratinizes around the teeth. Why? Because the tooth has a perontal ligament, and the perontal ligament cells have the biologic potential to induce keratinization. And this is very important. So one important conclusion for us as clinicians is that once an implant is losing the keratinized attached mucosa, this mucosa will not regenerate by itself, but we need to use a graft that will enhance keratinization, okay? So what about recession at implants? Why do they develop? We have some reasons. You look at this case, this is a patient that exhibited recessions around implants. And in fact, we have to look at some etiologic factors. And the key factor for the development of soft tissue recessions at implants is always then the implants do not go by themselves outside the bone. Somebody is placing the bone. And usually this is the main cause, the main problem associated with this complication. So I try to summarize some of these factors, and they may be related to the incorrect implant placement. For example, the implant is placed far too vestibularly or orally, or maybe the bony envelope is not sufficient. We may have also discrepancy between the size of the implant and the available bony envelope, or maybe the implant is placed far too close to the tooth, or maybe two implants are very close to each other. We may mucosa, the thickness of the mucosa, or maybe we may have a combination also of an infection, peri-implant mucositis or peri-implantitis. Let me show you some cases. Look at this case. In this particular situation, difficult to correct and to manage from a biologic point of view. Another case, and the third case, where we have the implant that is placed a little bit too far labially. Here, the recession is not very dramatic, but you can clearly see, in fact, the titanium shining through the tissue. Then, of course, we may have a lack or maybe an insufficient thickness of the bone. How much thickness do we need? 1.5 to 2 millimeters is mandatory. And if you don't have this bone, then what is going to happen is that the soft tissue recedes. Why? Because the soft tissue always follows the hard tissues. It's very important to keep this in mind. Look at this particular case. Here, the implant was accommodated in a correct position. Sufficient attached gingiva or attached mucosa in this case is present. However, there was a lack of bone. And what happens over time is that the soft tissue is receding, and basically we have, in fact, a recession of the soft tissue of about 2 to 3 millimeters. If this happens in the posterior area of the oral cavity, basically this is not a big problem, but if this complication occurs in the aesthetically demanding area, that can be really a disaster for the patient. How can we prevent such a problem? By using a GBR, a classical GBR procedure, by using a contour augmentation, using some slowly resorbable biomaterials combined with autogenous bone, and of course, using some native collagen barriers or some other collagen materials. And this soft tissue will be stable due to the fact that the bone is restored, and the height of the bone will always support the height of the soft tissues. And this will end up in a healthy, infection-free, inflammation-free soft tissue. What about if we do not have enough space for the titanium? In other words, we have a discrepancy between the size of the implant and the bony envelope. You know, in this particular case, the implant was accommodated in a correct position. However, the diameter of the implant was quite wide. It was a 4.1 millimeter implant placed in the in an area, in the aesthetic area, where the thickness was not sufficient. And over time, the bone, the available bone, the rest bone, resorbed, and you see this small hole over this implant. It is not a peri-implantitis, but this is an excellent entrance for bacteria. What about another complication that may occur? If the implant is placed too close to a tooth, then we may lose the papilla. And there are also some other situations where the implant is placed on the tooth. And then we may have even an implant with a viable parodontal ligament. However, this is not the main option and the main expected outcome of the treatment. So we need to have at least 1.5 millimeters between a tooth and an implant in order to maintain the height of the papilla. And of course, the distance between the contact point of the crown and the bone level needs to be of at least 5 millimeters. Otherwise, again, the papilla will be lost. Another problem that we see in our patients, there are too many implants placed, and especially if the implants are too close to each other. So how much space do we need? At least 3 or 4 millimeters. Otherwise, the papilla is going to get lost, and this is a catastrophic situation because nobody can regenerate this situation or this papilla. Look at this case here in the mandibular anterior area. 2 diameter-reduced implants were placed. Everything was okay, but the implants were too close to each other. We would never place 2 implants in the mandibular anterior area because this will lead to a loss of the bone. Look at this bone loss after 1 year. And of course, the papilla is going to be lost as well. And this cannot be corrected. The only way to correct the situation is to remove one of the implants or maybe both of them to try to rebuild the lost bone and then to keep the implant and restore the implant with a crown and use a cantilever. What about if you have a thin mucosa? If you have a thin mucosa, then we need to increase the mucosa thickness because this will result in an unstable clinical situation. And what is the best way to do that? Use a connective tissue, harvest it from the palate, take the connective tissue and suture the connective tissue in the best way at the inner side of the flap, because in this way, we are going to ensure vascularization of the graft, and also the connective tissue is enhancing keratinization. So basically, we are going to enhance keratinization and increase the soft tissue thickness. And this is a very simple method that is very successful, and it gives a lot of clinical benefit. So what about another case? Look at this case as well. Here, the implant was accommodated in a correct 3D dimension. However, when we look at the case, it is obvious that we have a very thin mucosa, and probably during the surgery, some tension was present as well. So what happens here is that we have a dehiscence, and this dehiscence is in fact an excellent entrance for the bacteria. And of course, the aesthetic is also not perfect. What about implantation? We have stable, this is a better. This is very important. However, we may also have soft tissue loss in cases where we have deep pockets already. So this patient was referred to me for recession coverage, but when you look into more details, then you will find this swollen papillae, and it is very important to analyze the case in detail. And in this particular case, it is obvious we have to deal with a severe infection, and some of the implants need to be removed. So these recessions cannot be covered because look at these deep pockets here, up to 10, 11 millimeters. So this is the most important message. Try to prevent much more and much more predictable. I can tell you this. What about the treatment goals at the implants? We have 2 treatment goals. The most important is to help the patient to clean better, to prevent periimplant mucositis and periimplantitis, and of course, to improve the aesthetics, especially when the implants are placed in the aesthetically demanding area. And this treatment should result in a stability. What do we know from the literature? The literature says that treating a recession around an implant or on the tooth because we have biologic differences. And in fact, so if I have an impossible, like this particular patient, you see here, the implant is placed completely outside the bony envelope. moved is the explantation and then another treatment option. Then I started to go ahead and try to treat the cases with part of soft tissue. We would have without soft tissue augmentation anatomy of the tooth. So I use modification of the soft tissue grafting technique, the so-called modification of the tunneling approach, using specifically designed instruments in order to enable the regeneration of this tissue. So I don't cut the papillae, but basically I mobilize the tissue, I harvest the connective tissue from the palate, insert it in this area, and move everything coronally. And basically, this gives a very nice aesthetic outcome without any scar tissue formation, at least no visible scar tissue formation. And we have, in fact, a stable clinical and aesthetic situation over the years. Look at this particular case as well. Here again, we have a patient. I treated this patient more than 12 years ago. You see this problem in this central incisor. She has an aesthetic complication here. And in fact, she wanted to preserve the tooth because in this particular case, the dentist, but of course, this you end up in a very, very bad situation for the patient. So what we do in such a case is to clean the surfaces of the roots. And in fact, what I'm doing here is to connect the recessions, you know, the recession that is at the crown restored central incisor with the recession over the canine. And basically, what we do is to very, very gently clean the surfaces of the teeth, and then to try to prepare a so-called full thickness tunnel using microsurgical instruments that will enable the placement of a graft in this particular area. So basically, what I'm doing here is to try to mobilize the tissue. That's very, very important. Keeping the papillae because I want to keep always this blood supply. And then what we do here is to prepare a tunnel. You see it here. I just go a little bit faster and then make sure that I can insert here a connective tissue graft, pull it down, and move everything coronally with so-called sling sutures. And this treatment will end up in a stable situation. A very stable, complete coverage of these defects, stable over several years. Of course, I also did the other side at a later time point. So what about if we have an implant and the crown restored tooth, as we have this particular patient that was unhappy with the symmetry in the soft tissues, a patient by Professor Belzer from Geneva. We worked together in many aesthetically demanding cases. And here again, I use the same concept. I didn't mobilize the papillae. I just undermined the tissues using a connective tissue harvested from the palate side. Fixed only. And you can see that this crown is now with about 2 millimeters, and we were able to restore the aesthetic line of this patient. So when we use this technique, we have a very good stability of the blood supply and of the blood clot. And we have a number of cases. I don't want to go now into the details because we don't have that much time. But also in this particular case, if you look at the situation before and after, you can see where the lady has lost either due to an accident, she had a high smile line, and she received an implant in the area of the 1-1. And you see the problem. She was unhappy with the soft tissue configuration at the implant because it was not exactly the same as around the natural tooth. And basically, what we have to do here is to work always in a group, to work together with a restorative dentist, because otherwise we cannot treat this case, we cannot cover this ceramic restoration just with a soft tissue graft. So what we do here is to remove the crown, then we prepare temporaries. Of course, this is done by the prosthodontist. Then we go ahead and we have the soft tissue augmentation, but we need a concavity of this crown. It is very important because this concavity will guide, in fact, the graft. And what, in fact, we do here is to try to augment as much as possible with autogenous tissue, because the autogenous tissue has the unique increasing in thickness over time. And then with the final crown, we obtain a very nice facial contour of the soft tissue, and this contour is stable over the years because we have ensured both components, the soft tissue, and of course also a very nice emergent profile of the final prosthetic restoration. So how do we move ahead and try to restore recessions at implants? So what I do in my cases is the first step is to look at the possibility of having a pocket or not. So that's very important. So if you have a perimplantitis, you have an infection, never do a tunneling. So these techniques are only meant to restore the soft tissues, okay, not for treating perimplantitis. This is a colleague of ours, and she had lost the lateral incisor to 2, and you see the pink ceramic and the ceramic that was here placed on this implant. She also has 2 recessions and the neighboring teeth. And this is, in fact, a very good indication for a treatment, because the implant is located between 2 teeth. And this is the key element. If the implant is located between 2 teeth, and we can very nicely maintain the height of the interproximal papillae, then we can be successful. And this is just to demonstrate how we use, in fact, the connective tissue graft. We fix it at every single tooth, stabilize it, and move the tissue coronally in order to submerge completely the graft. And I try to go as far as possible in a coronal direction, because in this way, I can regenerate the soft tissues and even improve a little bit the black triangle. So this is the outcome. And please observe, we have very nicely regenerated the soft tissues, not only above the implant, but also on the neighboring teeth. Look at this case. Here we have 2 implants accommodated in the area of the premolars, and also very deep recession at this buccal aspect of the first molar. Here I combine the technique. I combine the tunneling approach with an envelope approach, because this buccal root was far too much outside the bony envelope, using the connective tissue grafts and trying to cover everything as good as possible, and moving, in fact, the soft tissue coronally, closing the flap, and the healing indicates a very increased tissue thickness, a stability of the tissues, and also an increase in keratinization. And this is one case that is very interesting, because this implant is a 12 millimeter diameter reduced implant, bone level implant. You see the position in a 3D dimension of this implant is quite okay. However, this implant had some dehiscence some sloughing in the soft tissue and a small recession. And this probably occurred due to maybe a tension in the soft tissue flap during the surgery. We have here two indications to treat. One indication is to improve the aesthetics. And the second indication, of course, that's the most important, is to close this entrance for the bacteria, because if we leave it like that, this will convert automatically in a peri-implant mucositis or in a peri-implantitis. So what do we do in such a case? In fact, the tissues are quite healthy. We have maybe a very slight peri-implant mucositis. I like to clean the surfaces of the teeth, and if I have the implant surface, I also clean a little bit the exposed parts. And then we use very, very tiny instruments, microsurgical instruments that are aiming to preserve the entire area of the soft tissues. So by using these intraocular incisions with the microblades, I can, in fact, reflect and prepare the tunnel, but always make sure that the tunnel is very, very mobile, because during the placement of the implant or during tooth loss, after tooth loss, we always have a scar tissue. So basically, the preparation of the soft tissues around the implants is always more difficult than around natural tooth or natural teeth, because we have, in fact, always the scar tissue fibers that attract and try to immobilize this area. So that's why I go quite high up in the vestibulum, maybe 3 to 4 centimeters, using these microsurgical blades, and I release the fibers as good as possible, because these fibers need to be released and need to be removed and cut. And you can easily check the tension of the soft tissue by moving a curette in contact with the inner side. The fiber that may surface. So the next step is the connective tissue, because in the very end we are dealing with an avascular surface like titanium or ceramic. We need living tissue, and this living tissue has to be harvested from the palate. And very recently we published an article about an extensive study where I harvested 64 human biopsies from the various portions of the palate, and we looked with a gene array technology on the different genes that may be up and down regulated in the different parts of the palate. And very interestingly, when we harvest connective tissue from the posterior area of the palate, in fact, we have a higher possibility to upregulate BMPs, and BMPs have very for genesis. So in fact, what we found is very interesting, because if we have grafts harvested from a posterior part or from the tuberosity, these grafts may have a higher potential to be stable and to induce also some bone formation. But this is now the biology behind. Clinically and practically, we need to insert the graft and we capture graft using our microsurgical instruments, using the so-called tissue tweezers, tissue pliers that stabilize, in fact, the graft in a much better way, and just very simply pulling the graft into the tunnel. And for this, it is mandatory that the tunnel is very well prepared, because otherwise this graft will be stopped by the fibers. So that's very important. Then I like to stabilize the graft at one end of the tunnel under one of the papillae, and then you pull it to the other direction, stretch it. In a way, we would stretch a membrane, but we have to make sure that the sutures that insert in this area, they are always coming from the same direction. Otherwise, we have a high chance that this graft is going to turn in the tunnel. And in fact, we want to have a position of the graft as we have it with a membrane and not with a sausage. So that's very important. And our dental assistant is pulling the graft in the very moment I want to have it inserted and stretch. And we stabilize the graft with sling sutures on the cervical part of the implant using sutures that are short. They have short needles, maybe 10, 12 millimeters, because in this way I can have the fine movements in a very much more precise way, stabilizing the graft. This is very, very important because the graft has to be stabilized. In the very moment the graft is not stable, then the newly formed tissue, the keratinized tissue, will not be stable either. So that's very important. Wound stability will offer a very predictable result. And I like to emphasize always the need for having very precise sutures. And then we close the soft tissue above this connective tissue graft using either a sling suture, or in certain cases, we can combine the sling suture that will move the soft tissue coronally with a lateral closure. And we always have to take care. You see this small periosteal elevator that we do not capture with our needle tip the graft. So in this way, we have a very stable clinical situation. And of course, it is very important to stabilize the graft at the neighboring teeth as well, because in this way, I stretch the graft and I offer stability at both the teeth and around the implants. And in this way, I offer the best wound stability for this operative area. You can see the sling sutures that are quite easy to be learned if you attend one of our courses, and you can use them in very different clinical scenarios. So when we look at our outcome, the outcome is stable. I was able to regenerate the soft tissues. The aesthetic appearance is, of course, also better, but most importantly, I was able to close this entrance for the bacteria. So let me come to some conclusions. Current evidence suggests that the coverage or regeneration of soft tissue defects at implants is only possible if the implant is accommodated in an acceptable 3D position. That's very important. Second, the surgical techniques that I have described are quite predictable. Of course, for well-selected cases. And for further information, you can contact our group. And of course, you are welcome to visit us. Very happy for this opportunity to lecture at the National Day of Romanians. I greet you and hope to see you soon. Thank you very much.